significant challenge with that, with the sperm making that journey from the vagina all the way to the fallopian tube. So because of this, God gave man wisdom to be able to achieve fertilization outside the body, outside the fallopian tube. God gave man wisdom to know what is required, the environment that needs to be created for fertilization to occur outside the body. So that is what in vitro fertilization means. In vitro, IVF, means in vitro fertilization. And if you see the next slide, you see the test tube baby. So before, that is what they were referred to. They were referred to as test tube babies. Why? Because the fertilization was achieved in the lab. It was achieved in the lab, it was achieved in tubes, it was achieved in the petri dish where egg was placed and sperm was also placed, and the sperm fertilized the egg in the dish, and then the fertilized egg was placed in the incubator to incubate for some days, and then the resulting embryo was then transferred into the uterus, the womb of the woman. So what IVF simply therefore means is that you need to be able to achieve fertilization outside the body. For you to be able to do that, it means that you must be able to retrieve eggs from the woman, because eggs are required. And so you should be able to retrieve eggs from the woman. You should be able to get sperm from the man, put both of them together inside a dish, and then you will achieve fertilization. And after some days, the fertilized egg, now called embryo, that has grown, that has continued to divide and has grown to a certain stage, whether day 3, day 2, day 3, or day 5, will now be transferred into the womb. So you can see the diagram on the first, the IVF process, where you have the egg retrieval, you have the fertilization, and you have the culture, and then you have transfer. The second slide also tries to depict that the processes that must be involved, it must include egg collection, it must include insemination of the sperm and the egg, and then you culture, and the resulting embryo is then transferred into the uterus. So this is essentially, next slide, this is essentially the processes that are involved in the IVF process. All right? So to summarize the process, the first thing you must have what we call the controlled ovarian stimulation. What that simply means is that the woman is given medications, injections, to help to stimulate her ovaries to produce eggs. Again, in the natural cycle, the natural process of reproduction, a woman who is undergoing cyclical menstrual flow is expected to release one egg every month. What that means is that the ovary they would recruit a cohort of eggs, of follicles, and those follicles will grow, and inside each of those follicles are eggs, oocytes. So those oocytes will grow, but in natural conception, it's only one or two eggs, that one or two follicles that continue to grow. Others will just grow off. So it's only one, and then that is referred to as the dominant follicle, and it's that follicle containing an egg that gets to release the egg on the day of ovulation. So during natural conception, it is one egg that is released, usually. Although sometimes you may have two eggs that are released simultaneously, but usually it's one egg. And it is that egg that finds its way into the fallopian tube in the ampullary region that gets fertilized. However, in IVF process, because more eggs will be required for the process, and because injections are usually given to stimulate the ovary to produce eggs, it's not just one egg that is produced. So because of the injections that are given, what we call the gonadotrophins, multiple eggs are produced. So what usually would happen is that all the eggs that have been recruited, all the eggs that were recruited, they will all grow in maturation because of the injection, the medication, the gonadotropin that is being given. Specifically at the initial stage, you're giving either the highly purified um, follicle stimulating hormone or the recombinant follicle stimulating hormone, or you can use the human menopausal gonadotropin. All right. So these are the hormones that are given, and what it does is that it stimulates the ovary such that all the eggs that are recruited in that circle all to maturity. That is how you have multiple um, follicles, and then you have multiple eggs being retrieved. So once you take the patient through this process, usually the stimulation is usually for about 10 to 12 days. All right. And then you give the last injection to trigger final maturation. Now, the same hormone that is released to bring about the ovulation of an egg in a natural cycle, that same hormone or a similar that a hormone that has similar properties, what we call the HCG, human chorionic gonadotropin, is given at a specific time once we have confirmed that the eggs are matured or they've gotten to a certain size, the follicles have gotten to a certain size, the injection is given to bring about the final maturation of the eggs. And then the 36 hours after that last injection is given, egg retrieval will be done. So egg retrieval is not a painful procedure. A lot of patients think that IVF is painful because on the day of the retrieval, you will go through pain. No. For us at the Georgia Abebe Fertility Center, we do our egg retrieval under anesthesia. All right. Well, let me just say this for those who are listening right now. If you have any question, please just do indicate and send the question to us on the chat box. We'll be glad to answer all the questions at the end of this session. Right. So the egg retrieval is done after 36 hours that the HCG is given, and then the eggs are screened, the eggs are collected, and then insemination is done with the sperm of the spouse. And after 18 hours, 16 to 18 hours, you check for fertilization. And once you've achieved fertilization, the fertilized egg is put in the incubator to incubate for either 2, 3, or 5 days, and then transfer is done. It's important to state here that the process of insemination depends on the quality of the sperm. So for some patients whose sperm parameters are normal, within the range for conventional IVF, that is what will be done. Conventional IVF will be done where the egg and the sperm will be placed together inside a dish, and the sperm is expected to swim and fertilize the egg. However, if the sperm quality is poor, such that we don't anticipate the conventional for the sperm to swim and fertilize the egg, what we will do is what we call intracytoplasmic sperm injection, ICSI. What that simply means is that the sperm will be collected, and through a special machine, it will be injected into the egg. And all of this, what it does is to facilitate fertilization. So once that has been done, you culture, and then after either on day 3 or day 5, the embryo transfer is done. For us at the Joja Baby Fertility Center, we usually do the 5 transfer, meaning that the embryos would have stayed in the incubator for 5 days before the transfer is done. The transfer is done on the fifth day or on the sixth day in some cases. Why do we prefer the fifth day to the third day? Because it gives us um, room for us to be able to select the best embryos because they would have gone through a series of culturing and division, and at the end of the fifth day, which is the blastocyst stage, we would be able to tell embryos that have done very well. So after the embryo transfer is done, which is not painful, the patient is counseled and then given medications to support the pregnancy. And 2 weeks after the embryo transfer is done, pregnancy test is done, and hopefully the patient gets pregnant. We look forward to our patients getting pregnant because that is one of the hallmarks of the process. And we are very particular about our outcome, and that is why we provide personalized care to our patients. Now, the next slide, you'll see what a normal follicle looks like. This is an ultrasound done of a patient, and this particular follicular, this picture, is a patient with a polycystic ovary. This is the way a patient with polycystic ovary, the picture appears on scan. You can see the small follicles, those black spots round the ovary, what we call the eccentric arrangement of the follicles at the periphery of the ovary, leaving the central portion bare. That is typical of a patient that has polycystic ovary. All right. And then the next slide, during the course of the stimulation, you see those small follicles in the first, in the normal follicle, you see they become bigger. As you give injections, those follicles begin to grow in size. And so you continue to do your scan. So typically the way we do our scan is that you do the first scan, which is on day 2 or day 3 when you are commencing stimulation, to rule out any ovarian cyst. If there are, you want to probably drain it or um, cancel that program and ask the patient to take some medications, and then you see her in the next period. All right. But once there is no cyst, you will start your injections. Now, suffice to say that there are different kinds of protocol for stimulation, for controlled ovarian stimulation. There are different protocols. You have the agonist protocol, and then you have the antagonist protocol. Under the agonist protocol, you have the long agonist protocol, you have the short agonist, and the ultra short agonist protocol. So, depending on the patient's profile, you would have to determine what protocol will be best suited for the patients. But all over the world, the most preferred protocol for most patients will be the antagonist protocol or the agonist protocol. The short protocol can also be used depending on the patient's profile. I don't want to go into details on for that. I think that will be beyond the scope of this general knowledge session that we are. But suffice to say that you would, after you have gone through your evaluation, your test, your doctor would, based on your profile and your test, determine what protocol will be best suited for you. Okay, and so, but you will need to go to take injections, and when you're taking these injections, you're going to be coming for regular scans. So they'll scan you on day 2 to rule out any cyst, and then you start off. Then after 4 days, you come for your a repeat scan to see how well you are responding to the injections, and thereafter, every other day you'll be scanned until we get to the point where we are convinced that the follicular size we have achieved it, and then you will be given your final injection. And so you see the cause protocol, you see there the long agonist protocol, and then you see the antagonist protocol. All right, so that is why, see, two patients may not go through the same protocol, and that is why it's not also nice for two patients who are going through a program in a fertility center to begin to compare the treatment they are having. Because, like I said before, at the Joja Abebe Fertility Center, we try to provide personalized and individualized uh, treatment service to our patients. All right. So the next slide, you're still seeing the protocol. Like I said before, you have the antagonist protocol, and then you have the agonist protocol, which again can be divided into long and short protocol. All right. The difference between the antagonist and the agonist protocol is the type of medication that is used for down regulation and when that injection is started. Now, when we say down regulation, we mean an attempt to take over, to suppress your body from responding, and then we will not be the one to determine how your body responds. Yeah, there are injections, there are medications that can be taken to be able to achieve that. All right. So after that, after you've gone through the controlled ovarian stimulation, like I said before, which is usually for about 12 to 14 days, leading to the final maturation, the injection you take, after 36 hours, you will be ready to have your oocyte retrieval. So typically what will happen at our center is that while you are taking your last injection, you'll be given all the necessary briefs, all the do's and don'ts, and then you would be required to do a progesterone test on that day of the trigger injection. That is very, very important because it helps us to determine patients who would go on to have a fresh transfer and those who may need to have their embryos frozen. All right, because a level beyond a certain limit would mean that the endometrial receptivity would have been significantly affected. So it's very important for us we do that in our center to be able to determine patients who can go ahead and have a fresh transfer and those who need to